Bismillahir Rahmanir Rahim. Assalamu alaikum. Hello and good morning, everyone. This is Dr. Taha Yasin from Department of Gastroenterology at Bahrain Specialist Hospital. And today I'll be regarding some insight. I will be giving you some insight regarding the management of the chronic diarrhea. To begin with, there are no conflicts of interest for this presentation. And the learning objectives are approach to chronic diarrhea using pathophysiology, recognizing evolving diagnosis over time, managing complex malabsorption and its complications, avoiding diagnostic anchoring. So, what is chronic diarrhea? It's the passage of loose or liquid stools, urgent need to evacuate, or feeling of abdominal discomfort, or increased frequency of all these, lasting more than 4 weeks. So, there are different types of chronic diarrhea, and they cause persistent distress. They can cause functional impairment and nutritional deficiencies. That these all can lead to poor quality of life in patients with chronic diarrhea. So approximately 55% of the gastrointestinal outpatient department visits worldwide account for like chronic diarrhea. And this incidence varies widely, and it is influenced by multiple factors like geographical location, dietary habits, sanitation standards, prevalence of certain infections. So the clinical challenges are it's a diagnosis. There might be some diagnostic complexity. When a patient presents with chronic diarrhea, there might be broad differential diagnosis that can range from common functional disorders to rare conditions. Overlapping clinical presentations, often requiring meticulous assessment and repeated evaluations. Then that diagnosis might be delayed or it can be missed. The chronic diarrhea frequently leads to extensive diagnostic testing without definitive outcomes. Misdiagnosis or delays in diagnosis can lead to progression and complication of the underlying disease. Then there might be management pitfalls. Empiric management without thorough assessment may mask or complicate underlying etiologies. Poor adherence or response to conventional therapy can lead to refractory cases, challenging the treating clinician. So, how to investigate chronic diarrhea? There are some journal laboratory investigations. We start from simple baseline blood parameters, including the complete blood count, to look for anemia, thrombocytosis, leukopenia, or lymphocytosis, and also for the hematocrit, which is increase in dehydration. Then you have the electrolytes, renal functions, and because it can cause acute kidney injury, pre-renal azotemia, and then the electrolyte imbalances like hypokalemia, hyponatremia, and hypomagnesemia. Then there might be raised inflammatory markers like ESR and CRP. Then coming to the stool analysis. First, basic, including the stool for culture and the viral and bacterial PCR, stool for ova and parasite, stool for calprotectin, stool osmolarity, which is very important. And with the help of stool osmolarity, we calculate the stool osmotic gap. And then we go for testing for the type of anemia like iron profile, B12 levels, and the folate levels. Then there are some specific laboratory investigations. For Crohn's disease, we ordered the autoimmune serology. For celiac, we ordered the anti-TGG antibodies and the other EMA and DGP antibodies. And then there are, for tuberculosis, there are certain tests like tuberculin skin test, gamma interferon, and chest X-ray. So first of all, for the management, for the diagnosis of chronic diarrhea, history is very, very important. And if chronic diarrhea, it can be divided into inflammatory and non-inflammatory. In non-inflammatory, then we decide on the basis of the stool osmotic gap. If it's less than 50, 50 to 100 is the normal range. If it's less than 50, then we consider it as a secretory diarrhea. The causes are bile acid malabsorption. There might be medications. There hyperthyroidism. Then there are multiple endocrine neoplasia, which causes the secretory diarrhea, including the sub syndromes like vipoma, gastrinoma. Then the polyps, villus adenoma, microscopic colitis, protein losing enteropathy. These are the causes of the secretory diarrhea. Now, if the stool osmolarity gap is greater than 50, that we consider of osmotic diarrhea. Or what is osmotic diarrhea? The diarrhea which improves on fasting. The patient says, whenever I fast, so my symptoms improve. So that include the diarrheas like SIBO, and then there are fatty malabsorption and the lactose intolerance, and then there are fatty diarrheas which are malabsorptive diarrheas. That also can be because of the celiac disease, SIBO, tropical sprue, giardia, and bile acid malabsorption again. Then there are functional causes in which all the pathologies, including the endoscopy and colonoscopy, are all normal. Capsule endoscopy is normal. Then we consider IBS and autoimmune enteropathy. Next, which is very common in this part of the region, is inflammatory type of diarrhea, like Crohn's disease, ulcerative colitis. Then post chemotherapy and radiotherapy induced diarrheas. Then there might be malignant diarrheas. New onset diarrheas after the age of 45 to 50 years should be screened for any underlying malignancies. And then there might be the pathogens which can cause the inflammatory diarrheas. Now, it will be a case-based evaluation. So it's a first case. So it's a 22-year-old lady, South Asian lady. She's a university student, and she undergoes evaluation for complaints of loose stool for 8 months, which are watery, voluminous, associated with abdominal bloating, and relief with defecation. There is no tenesmus or passage of blood in stool. This complaint was associated with significant documented but unintentional weight loss of 10 kgs in 12 months. This was not associated with fever, joint pain, facial flushing, and palpitations. There was no history of TB contact, food allergy, prior drug intake, extramarital affairs, or travel abroad. In the past history, this is insignificant. It was not significant for anything. The personal history again was not significant, as was the drug and the family history. On general examination, she is a young lady with thin build, the blood pressure of 98/56 with postural drop, with no postural drop, heart rate of 82 beats per minute, respiratory rate of 16, temperature of 98.6 Fahrenheit. On general physical examination, she was pale, had koilonychia, with rest of the general physical examination, including the lymph nodes and the thyroid examination, being unremarkable. Her rest of the systemic examination was also unremarkable. So based on this, the differential diagnosis, considering the South Asian lady, was giardiasis, celiac, and considering the young patient there, it was Crohn's disease, followed by the tropical sprue. So how to investigate it? We investigated. The complete blood count was showed the hemoglobin of 8.9. WBC count was normal. MCV was 82. Platelets were mild on the higher side. It was thrombocytosis, 550. Renal functions were normal. LFTs were normal. HIV serology was also negative. Anti-TTG serology, which is one of the most common causes of diarrhea, chronic diarrhea in young female celiac disease, was also negative. Serum B12 levels were mostly on the lower side, but it was again in the normal range, because the normal range was between 180 to 1000. Serum folate levels was slightly on the lower side. Iron profile showed the transferrin saturation decrease with increased TIBC. Stool analysis was unremarkable. So this is the endoscopy finding. So this is the bulb of the duodenum, and this is the distal duodenum. And in distal duodenum, you can see there is mild fissuring with decreased heights of the duodenal folds as we progress further. And in the bulb of the duodenum, you can see that there is what we call as nodularity of the mucosa. So the biopsy was performed, and this biopsy showed you can see the cursor. So in this cursor, you can see there is increase in the intraepithelial lymphocytes, and this is crypt hyperplasia and moderate villus stenting. So villi are the finger-like projections. You can see here, these are the finger-like projections. I will show you in the subsequent images. Here, there are finger-like projections. When those finger-like projections are lost, as in any case of diarrhea, so that is called as a villus atrophy. So you can see here, these are the finger-like projections I was talking about. Right. So we classify any villus atrophy, any cause of chronic diarrhea, on the basis of the duodenal biopsy or the small bowel biopsy on Marsh classification. Now, initially it was Marsh classification. Now it's modified Marsh classification, having Marsh type 4 as well, in which there is complete loss of the epithelium. So in the Marsh class 1, there is only increase in the intraepithelial lymphocytes, while in Marsh class 2, there is with this increase in intraepithelial lymphocytes, there is crypt hyperplasia. While in Marsh class 3, there is villus atrophy along with all these three, all the other two things. And in Marsh class 4, there is complete loss of the epithelium. So the differentials were based on this. It was again, the celiac disease was lower down because the TTG serology was negative. However, we have not screened currently for HLA typing. The tropical sprue, considering the tropic region of India and Pakistan, so it is considered one of the differentials, and many patients improve on taking the antibiotics and the folic acid for 3 months. Then the other differential still was kept in mind was abdominal tuberculosis, inflammatory bowel disease, eosinophilic gastroenteritis, and autoimmune enteropathy. So how to proceed further? We did the HLA typing. It came out to be positive. So what are the indications of HLA typing in a patient who, if you suspect celiac disease? To exclude the possibility of the celiac disease. If HLA typing of DQ2 and DQ8 is positive, it has a high negative predictive value. If it's negative, you exclude celiac disease. The patient is likely to have not to have a celiac disease. Second, when you are uncertain regarding the diagnosis, you have the negative serology, but histology is likely suggestive of celiac disease. Then, to rule out celiac disease among the healthy siblings with asymptomatic relatives, like if a patient is having celiac disease, if someone is having celiac disease in the family, so the other family members should be screened by HLA typing. Patient with other autoimmune disorders, it is usually said when you have one autoimmune disorder, usually screen for other 7 autoimmune disorders, including thyroid, adrenals, diabetes, etc. So what is the diagnosis now? It is the celiac disease. A diagnosis. So how to now celiac disease? It's not the diagnostic dilemma. It's not that the celiac disease diagnosis is complex. It's the management which is complex. So at diagnosis, you perform the physical examination first and foremost. It's very important for a clinician to educate the patient regarding the celiac disease. What is it? And to in a positive way, that it will not hamper her lifestyle. Then dietary counseling by a skilled dietitian, recommended family screening, routine test which include the if not done previously, like thyroid function test or LFTs if not done previously, and recommend membership of celiac national society or support group. DEXA scan is very important at that time of diagnosis, but if the patient's presentation is more than 35 years, we can omit this thing. Now, nutrition consultation. These are the grains containing the gluten, which include the most common barley, rye, wheat, and all these things. Now, these are the gluten-free grains. Remember, among all these things, oats are usually gluten-free, but naturally, but they can be contaminated. Now, celiac disease is diagnosed. How to have a follow-up scheme of it? At 3 months, you have to assess symptoms, dietary review for the strict adherence to the gluten-free diet. You have to ask the patient whether she is taking any hidden source of gluten or not. Then you have to repeat the celiac serology. Remember, if the patient is taking any hidden source of gluten, celiac serology will be positive. Even in the patient with seronegative celiac disease, celiac serology might come out to be positive at any point of their illness. Then at 6 months, again, you have to review all these things. Now at 12 months, what to do? You have to perform the small bowel biopsy. You have to again do the endoscopy, go into the duodenum, take the snip, and then to document that the disease is in remission or not. Then at 24 months, you have to, if initially thyroid function tests were negative, then also, or if they were abnormal, then also you have to perform the thyroid function test. Then every 1 to 2 yearly, you have to perform the DEXA scan, thyroid test, celiac serology, everything. So when to check for macro and micronutrients? Yearly. So why not? It was a Crohn's disease. Yes, in this region, in Bahrain, we will first consider Crohn's disease. But in this celiac disease, why it was celiac disease? Because HLA typing was positive, and the patient was having chronic diarrhea, iron deficiency type, and women are more likely to be diagnosed with celiac disease as compared to men. And secondly, in Crohn's disease, men and women are equally affected. And celiac disease, when you take the history, the patient will tell you that my symptoms are aggravated when I am taking wheat, chapati, and all these things. However, Crohn's disease have multifactorial. It can be genetic. It's a combination of genetic and environmental factors. Okay, why not tropical sprue? So in tropical sprue, ileum involvement is greater than the duodenum, and it can also have the colonic involvement. And villus morphology includes the increase in the number of intraepithelial lymphocytes in both. However, in tropical sprue, eosinophil levels are also increased in the biopsy. And laboratory findings in celiac include the iron deficiency anemia. However, in this case, laboratory findings include the B12 and the folate deficiencies. Okay, then tropical sprue response to the antibiotic is positive in tropical sprue. However, in celiac disease, it will not respond. So these are the common mimics of celiac disease, including the Giardia lamblia, tropical sprue, and Whipple disease. However, Giardia lamblia, the patient might go to some restaurant, have the contaminated food there, milk, water, like that. And the Whipple's disease, it's a systemic disorder. Like it can present with the symptoms like arthritis, lymphadenopathy, and etc., and hyperpigmentation. So this was one of the case report which was published from our center there, and Whipple's disease it was. In this case, there was a young male who presented with the symptoms of like arthritis, and also had this hyperpigmentation. On duodenal biopsy, it was PAS positive diastase resistant material was seen, which was suggestive of Whipple's disease. It's a very rare disorder. It is not usually seen. So coming back to our normal case, 1 month later, our lady presented with abdominal pain, bloating, and diarrhea with flatulence, which was foul smelling. Although she says that she has been adherent to the gluten-free diet. On further inquiry, she added that her symptoms are aggravated after consumption of the food supplement. So stool osmolarity was done, which was greater than 100, with a stool pH of 4.6. Anti-TDG serology was again negative. Why the patient developed these symptoms? Because in celiac disease, there is lactose intolerance can also be present within first 3 to 4 months. So how to investigate lactose intolerance? The most accurate diagnostic test is lactose hydrogen breath test and small intestinal biopsy, which is not usually done these days. It is done to to assess the direct assay of brush border enzyme activity. So how will you treat her? Avoid the dairy products, lactose-free dietary supplements. So these are the foods that are high in lactose, including the milk, yogurt, beer, whey powder, pudding. So there are alternatives like coconut yogurt, avocado, nut milk, cashew cheese, coconut cream, and nice fruit-based creams. So when you counsel the patient regarding celiac disease, you can expect the patient might be having lactose intolerance in the first 3 to 4 months. And usually the patient reports that. So you can give this dietary alternatives. So 5 years later, the patient was asymptomatic. Our patient was asymptomatic, then she was fine for 5 years. Then after 5 years, she presented with diarrhea associated with tenesmus. Stool osmolarity was 34 milliosmol. She underwent colonoscopy and biopsy. Colonoscopy was normal colonic mucosa up to the cecum. Then the colonoscopy and biopsy showed these damaged epithelial cells. In this, these are the with increase in intraepithelial lymphocytes. Greater than 20 intraepithelial lymphocytes plus per 100 epithelial cells. So now the diagnosis was of lymphocytic colitis, microscopic colitis was made. So you can see here that celiac disease is associated with many conditions which can be autoimmune. And microscopic colitis is one of them. Most common is autoimmune thyroid disease, Addison's disease, and all these conditions. Now, she was treated with mesalamine and she was fine. So these are certain case reports of associated conditions with celiac disease. We observed non-alcoholic fatty liver disease in a young male with celiac disease. She basically this he was a young emaciated male with celiac disease, and he presented with severe electrolyte imbalances, and ultrasound was showed the fatty liver. Then we also saw the Budd-Chiari syndrome in a patient with celiac disease, which is a very rare entity. And then we saw this Jobs syndrome. This was Budd-Chiari syndrome in a patient with celiac disease, and now we saw the Jobs syndrome in a patient with refractory celiac disease. So Jobs syndrome is a syndrome in which increase in the immunoglobulin E levels. It is also called as hypereosinophilia syndrome. So we observed that this patient had the history of chronic diarrhea, recurrent skin infections, hypereosinophilia, and elevated serum IgE levels. So she, on the histopathology, he had that findings of refractory celiac disease type 1, and also the Jobs syndrome was diagnosed and was managed, and the patient was symptom-free later on. So then celiac disease is one of the most common diseases that can be associated with squamous cell carcinoma of the esophagus. So this was one unusual case of dysphagia with celiac disease. Then this unusual case of solitary rectal ulcer syndrome with celiac disease. So in this case, it was we saw in a 15-year-old boy that he had this diarrhea, and when the colonoscopy was done, the findings were suggestive of solitary rectal ulcer syndrome. Now later on, after coming back to our case, the patient was again symptom-free for 3 years. 3 years later, she presented with abdominal pain, bloating, and small bowel type diarrhea. Hemoglobin was 8.7 with high MCV of 104. Serum folate was fine. B12 levels were decreased. Now, what can be the interpretation? It can be the SIBO. How would you confirm your diagnosis? Yes, aspiration and culture of the jejunal fluid. Greater than 10⁵ anaerobic bacteria, CFU per ml. So what are the other tests for the diagnosis of SIBO? Most commonly used is hydrogen breath test. Then there are bile acid breath test and C13 or C14 D-xylose breath test. Then Colli-Papa test and Colli-Papa test and urine indicium. These are not commonly used these days. Small bowel follow-through was also done, which was normal. The treatment is rifaximin or antibiotics 550 mg thrice daily with prokinetics for 10 to 14 days. Encourage high fat, low fiber, low carbohydrate diet. Correct the nutritional deficiencies, including the fat-soluble vitamins, calcium, magnesium. Lactose-free diet in this patient was instituted again. 2 years later, now the patient is symptom-free. 2 years later, she presented with 8 to 10 loose stool per day associated with significant weight loss of 12 kgs in 8 months. On examination, she had bitemporal wasting and was emaciated. The rest of the examination was unremarkable. So how to investigate? The endoscopy was performed, upper and lower flow cytometry was performed, CT abdomen with contrast was done, 72-hour stool for alpha-1 antitrypsin was done, PET scan was done, because the celiac disease is associated with, if not adherent to the gluten-free diet, it can be associated with lymphoma. MRE was done and capsule endoscopy was done. So these are the capsule endoscopy findings, and you can see these are the ulcers or like, and there is a fissuring of the small bowel mucosa. Push enteroscopy was again showed there was a nodularity of the small bowel mucosa. Then the jejunal biopsy showed increased intraepithelial lymphocytes with crypt hyperplasia. These are the crypts hyperplasia and mild villus atrophy. You can see here mild villus atrophy is there. However, these are preserved, a bit preserved. So these are the immunohistochemistry strains which are used, stains which are used to diagnose refractory celiac disease. And these are CD3 and CD8 positive. So you can see this villi they have increased CD3 positivity, and here there was increased CD8 positivity. So diagnosis was refractory celiac disease type 2. So what is the therapy for refractory celiac disease type 2? It's again oral prednisolone 1 milligram per kg per day. If not responding, what are the other options? Oral budesonide, IV steroids, purine analogs, cladribine or fludarabine, anti-interleukin 15, AMG 7 and 4. It's a drug which is used in which is currently in the trials, or JAK3 inhibitor, auto stem cell transplantation. Now, 3 months later, the patient responded to steroids. This patient. 3 months later, patient presented with complaint of stool 3 to 4 episodes per day for 3 months, which were difficult to flush and malodorous associated with pitting edema above the knee. Stool for alpha-1 antitrypsin clearance was 60 ml per 24 minutes, and serum albumin was relatively very low, 1.8. So what is the most likely diagnosis? It's the protein-losing enteropathy. So what is protein-losing enteropathy? How will you evaluate? If the normal alpha-1 antitrypsin level is there, you will exclude the gut cause and you will rule out the other causes like of low albumin, nephrotic, liver, malignancy, etc. If there is increase in the alpha-1 antitrypsin levels, then you will see that if the patient is having steatorrhea or not. If the patient is having steatorrhea, you will go for the capsule endoscopy and followed by the small ball biopsy. And if it's no steatorrhea, you go for the endoscopy and biopsy. So treatment of protein-losing enteropathy: high fat, high protein, low fat, and medium chain triglyceride diet. And sometimes IV octreotide is also given. So 4 weeks later, this lady presented with severe tense abdominal pain, and CT scan abdomen showed thickened small bowel wall with perforation. Surgeons were taken on board, and patient required small bowel resection, keeping 40 centimeters of the jejunum with intact colon. So in the surgical notes, there were multiple perforations seen in the jejunum and ileum. Small gut resection from proximal jejunum to distal ileum was resected, and remaining length of the small bowel was very low, very less, 120 centimeters. So after that, the patient presented with chronic developed diarrhea after enteral feeding. And what complication has developed? The patient has developed this short bowel syndrome. And how will you treat? It's the dietary modification like high complex carbohydrates and medium chain triglyceride diet, soluble fiber and low oxalate diet. Avoid high fat diet and refined carbohydrate intake. So refined carbohydrate includes the wheat, the bread, pastas, pastries, fruits, etc. While complex carbohydrates include the whole grains, oats, green vegetables, etc. So pharmacological therapy, you give the PPIs for 6 months for acid suppression, antidiarrheals to decrease the stoma output, cholestyramine for bile acid diarrhea, oral calcium supplements, calcium citrate. Long-term management, dietary modification, fat and mineral supplements. In case of difficulty in eliminating the TPN, you use the pharmacological bowel enhancement therapies, which include the tidoglutide and growth hormone injection. Surgical, these are certain surgical techniques, but the most commonly used is the step procedure, which is a serial transverse enteroplasty, and mostly in most of the cases, because it can cause the intestinal fatty acid liver disease, so the intestinal transplantation combined with the liver transplantation is done. So the long-term complications, catheter-related complication, which include the infection of the catheter, breakage, venous thrombosis, and the parenteral nutrition-related, which is IFALD, intestinal fatty acid liver transplantation. Patient was commenced on the TPN, and after TPN, there was starting the TPN, suddenly the potassium decreased, phosphate levels go up, and the albumin levels were very low. What has happened to the patient? This is the refeeding syndrome. Suddenly you give the nutrition to the patient who is already malnourished, and the patient develops the refeeding syndrome. What is the key to manage it? Slow and steady. Day 1, 10 kilocalories per kg per day. Day 2 to 4, increase furthermore 5 kilocalories if the patient is tolerating. And till day 8 to 10, you can increase the caloric requirement. So the patient was fine then, and after some time, there was yellowish discoloration of the eyes. So the patient developed intestinal fatty acid liver transplantation, fatty acid liver disease, and underwent the combined intestinal and liver transplantation. So this is the summary, which is we started from the diarrhea. When we covered a few topics, and finally leading the patient went the intestinal and fatty and the liver combined liver transplantation. What are the pitfalls and pearls in managing chronic diarrhea? Diagnosis, early diagnosis is the key. Target investigations, nutritional vigilance, individualized diet therapy, and multi-MDT approach. So This was the data on the celiac disease, which is going to be published in February. So in our population, we observed that iron deficiency anemia is the most common presentation of the celiac disease. This is a meta-analysis and not the diarrhea. However, in the Western population, diarrhea is the most common presentation of the celiac disease. And these are the autoimmune conditions associated with celiac disease. And we observed that among them, the hypothyroidism was the most common autoimmune condition associated with it. And then these are the lab parameters which were observed in the patient with celiac disease. Now, this was another article which was published for the determination of celiac disease in patients with chronic diarrhea, and we observed that more than 50% of the patients had celiac disease in young population. Then in renal transplant population, we had this study, and it showed that multiple organisms were the cause of the chronic diarrhea. Then HLA typing. HLA typing in our population was helpful in patients who were transplanted. Those were the patients who had the HLA-DQ2 and DQ8 positive, and it was positive among the renal transplanted patients with chronic diarrhea. Thank you.